Okay.
So yeah, we're good now.
All right. Hi, I'm Chris.
Somewhere to sit where I can hold still for a few minutes.
All right. I'm Chris Foth. I'm an interventional cardiologist at Freeman. This lecture is on heart failure. I realize a lot of what you guys do is more of the acute management, but this is kind of just a general overview. So heart failure is really, a clinical syndrome. Pretty much anything that results in, the reduction in the ejection of blood or ventricular filling will cause heart failure. That can either be due to your heart just being weak and not able to pump enough blood, or what's also very common is your heart's just a little bit thick and fibrotic, and you can't let in the blood very well because your heart's not relaxing well enough, and then that's heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction is defined as less than 40%. It's also called systolic heart failure. Preserved ejection fraction is greater than 50%. That's also called diastolic heart failure. And diastolic heart failure means that it's just not relaxing as well as it should, and it's not letting in enough blood, and you're having the reduced cardiac output from not letting in enough blood to pump that blood out. But the amount of blood that it's pumping out is, adequate, greater than 50%. Recently, they added the heart failure with mid-range ejection fraction, which is 40 to 49%. That one functions more closer to heart failure with reduced ejection fraction. Some of the medications that are good for reduced ejection fraction are also good for mid-range, but this is how it's been delineated. There's different stages. Stage 1 is actually where you just have risk factors. This could be, your patients that have high blood pressure, diabetes, or a little bit overweight. They're at risk for developing heart failure, but they currently don't have heart failure. Stage B in the AHA is people that have heart disease. They could have left ventricular hypertrophy, which is a little bit of thickness, increased thickness in the muscle, or just decreased relaxation, or maybe their ejection fraction is not completely normal, but they have no signs or symptoms of heart failure. 3 is when you have either currently have signs of heart failure or previously did. And then D is the patients that are, just constantly in the hospital, in and out, and really require, intensive care. Then you have the NIHA, which is more of a functional classification. Stage 1, those people are living normal lives. They have heart failure, but they're doing great. Stage 2, they're doing pretty well. They can live, and do all their daily activities, but if, they have to go walk a long distance or exert themselves, more than what they usually do, they'll feel some, fatigue, palpitations, shortness of breath. The stage 3 people are the people that they're okay doing, very minimal activity, but anything more than that, they're having symptoms. And 4 is really the, more advanced people. Those are the people that they just can't even live their normal life without having significant symptoms. So signs and symptoms of heart failure. This used to be called the blue bloaters. So this is left-sided heart failure. These are people that are just not perfusing. So this means there's something wrong with, the left ventricle and the body's cardiac output. So you can get paroxysmal nocturnal dyspnea, which is where you're sleeping at night and you just develop shortness of breath just while you're sleeping. If we do a right heart cath, you can have elevated, let's see where the pointer is. Oh, it doesn't go on the screen. So pulmonary capillary wedge pressure is something we measure in a right heart cath. That just means that the pressures in the heart on the left side are elevated. Pulmonary congestion, when you listen to their lungs, they're crackling, wheezing. Sometimes you can get blood-tinged sputum, which I have another slide on this. It's more of a cardiac asthma situation there. But they can have cough, shortness of breath. On the right side, they can feel very restless just from not feeling well. They can become confused. They can develop orthopnea, tachycardia. Tachycardia is usually a compensatory adaptation to what's going on. If your heart can't pump enough blood with each beat, the only solution for it to produce more cardiac output is to pump faster. So less with each beat, but faster, and you're still pumping, more blood around the body. Obviously, exertional dyspnea, fatigue, cyanosis. If you see, someone in heart failure and their extremities are blue, those people are not doing well at all. Yeah.
Nope, you're good. I'm switching. I got your presentation up, so
Okay.
I'm switching over to a different one.
Okay.
Should be good to go.
Okay, cool. Right. So this is right-sided heart failure. This is fairly common as well. A lot of these people are overweight, and that's really for two reasons. One, you get increased pulmonary pressures, especially if you untreated sleep apnea, things like that. And you get more of the right-sided heart failure symptoms, which would be, pre-lung symptoms, as opposed to the left ventricle not doing its job. Now the blood's just not really making it through the lungs, and it's backing up in the right ventricle, right atrium, and subsequently the rest of the body. These people, their main complaint is usually swelling. And you can obviously get, swelling and edema with left heart failure as well. But these people have, usually normal ejection fractions. They'll have elevated pulmonary pressure. They'll have just swelling that's been going on for years, as opposed to something that comes and goes depending on their diuresis and volume status. A lot of these people, up top right, they have, a lot of times it is secondary to chronic lung issues. And that's just increased pressure in the lungs. If the blood can't make it through the lungs, then you end up with it backing up and causing right-sided heart failure. A lot of these people will get abdominal ascites, which is an issue with medications. Lasix absorbs significantly worse when people have intestinal edema. Other diuretics like Bumex, which is bumetanide, or torsemide, they'll both absorb even if you're having significant gut edema. But Lasix is, the most commonly prescribed one, and that one's bioavailability just goes to complete crap if you have ascites. Pitting edema, it's just a scale. Push in there, and however long it stays, you roughly just estimate. Jugular venous distension, this is probably a big one. If you see a patient and they have this, huge jugular vein, pulsating out there, they're probably volume overloaded. A lot of people, unfortunately, can't really see the neck veins, but this lady's skinny and you can see it very well there. Cardiac asthma, so this is actually, we have a slide on what it looks like. These are the people you intubate and you get this crap. This is actually just fluid that's been pushed through the capillaries of the lung into the airspace in the lung and comes out looking like this. This looks white on the screen here, but it actually comes out usually looking a little bit pink. So that's from, congestion in the lungs, usually due to left heart failure, and the blood's just backing up in the lungs. And then the pressure in there is just pushing it out of those small blood vessels in the lungs and into the alveoli and alveolar sacs. These people, if you see this, these people are not doing well at all. Different causes of cardiomyopathy. There's a whole slew of them. This is more of a chronic medical management thing, but you can have dilated. Some of them run in families. You can have endocrine disorders. The biggest thing is thyroid problems. We always check a TSH on everyone just because that's low-hanging fruit. If your TSH is 100 and your heart's weak, it's probably due to lack of thyroid hormone. You can get from toxins, people exposed to heavy metals. Down at the bottom, there's iron overload. That's usually a genetic disorder, more so than something you can get from the environment. You can have peripardium cardiomyopathy, women that, either during the end of pregnancy or immediately after pregnancy develop a weak heart. That usually recovers. Tachycardia-induced cardiomyopathy is fairly common. Those are your people that are in atrial fibrillation or atrial flutter, just going super fast, have no idea that they're going fast, and then a month later the heart just becomes tired and becomes weak from that. Controlling the heart rate usually helps those people, and it usually recovers very well. Another big one at the bottom is stress-induced cardiomyopathy. These are predominantly women, but can happen to men as well. And basically you just see a stressful situation. Your spouse, falls and injures himself, or, people that are cut off and they have to slam on the brakes and nearly avoid a car accident can develop this. Just anything that's stressful. Those people usually do very well as well. Just start them on some beta blockers in the hospital and they usually end up with a recovery of their ejection fraction. So what to ask when you see the patient? This is probably a little bit more in depth, but just see, what exactly went on recently. Not as many people go through cruises here, but I did general cardiology in Miami, and everyone go on a cruise. The Food on cruises is extremely salty, so these people would come back in heart failure pretty consistently. As far as diagnosing idiopathic dilated cardiomyopathy, you really need a 3-family, history for that. But that wouldn't be anything you guys really deal with. Ask about what their activity level is. I have a lot of people that, they say they don't have any symptoms, but they don't do anything. You really can't say that you don't have symptoms if you're just sitting in a chair all day. Fairly common things to look for is people that sit in recliners, especially if people are sleeping in a recliner. That generally means that they can't lie flat. When you lie flat, the fluid in your lungs redistributes up to the upper portions of your lungs. And those are the areas that are generally perfusing during the day, perfusing and ventilating. And then at night, if you fill that all up with fluid, you're going to feel very short of breath. That's another reason why people sleep with more pillows at night. It's kind of getting that recliner position of you're a little bit more upright, so the fluid's at the bottom of your lungs, and you can ventilate the top parts of your lungs. Shoes not fitting is actually fairly common. People just develop such significant swelling that they tell you they can't put their shoes on anymore. Weight gain is an important thing. When we see people in heart failure clinic, we try and get them to what's called the euvolemic status, which is basically their amount of fluid in their body is where it needs to be. They're not too dry, they're not wet. And then we establish that as their dry weight. And we tell them, if you gain more than 5 pounds in a week, give us a call. If you gain more than 3 pounds in a day, give us a call. People that are usually pretty stable without diuretics, sometimes we'll tell them to only take the diuretic if they gain, more than 3 pounds in a day, 5 pounds in a week. Serial weight measurements are really important chronically. Some people will, especially people with preserved ejection fraction, their line between doing fine and being in exacerbation is a significantly smaller amount of fluid than people with heart failure with reduced ejection fraction. People, with reduced ejection fraction with weak hearts, they can gain, 30, 40 pounds before they present to the hospital, which sounds crazy, but is unfortunately fairly common. People with preserved ejection fraction, they can gain 5 pounds and they end up in the hospital. It's just the, different pathology of each one. You can gain a lot more weight with the reduced ejection fraction before having symptoms, because basically having more volume in your body, then you're actually increasing your cardiac output up until the point where the fluid's now in your lungs. Whereas preserved ejection fraction, their issue is not ejecting the blood, their issue is where it backs up in their lungs and just a little bit more fluid and they start having it backing up in their lungs. Potential clues. This is probably more of a chronic slide, but weight gain, ICD shocks can be another thing. Weight loss, it's called cardiac cachexia, which is basically just whenever they eat, and it's usually from being so fluid overload, they just feel full, and they just stop eating and they eventually waste. Recent illnesses can do it. If you develop the flu, a lot of people end up in heart failure shortly after that. Sleep apnea is a huge thing. We have further down, disordered breathing at night. Sleep apnea is a vicious circle. Usually leads to definitely leads to worse cardiac outcomes, but can definitely lead to worsening of heart failure. If their CPAP's no longer working, that can be a reason that presents them to the hospital. Oddly, we have a lot of patients that will just entirely stop their medication. They're just sick of taking it and they stop it. Those people, it's really tough because you have to slowly restart the medications. Diet's a huge thing. Medications that exacerbate heart failure, people taking NSAIDs and that. NSAIDs will cause fluid retention, sodium retention. It can also cause swelling of the legs. But people that, start taking those for a few days, have a high salt diet, they'll end up in the hospital. Adherence is unfortunately a huge thing too. Physical examination. Being overweight, unfortunately, contributes to heart failure, which is fairly common in the country. But then also being extremely skinny is also not ideal either. A lot of these patients will have orthostatic hypotension where they're doing fine sitting, they get up and their cardiac output just drops. That's a combination of both the illness and also the medication that we have them on. All of those medications are going to lower your blood pressure a little bit. especially people with heart failure with reduced ejection fraction. There's 4 medications that we try and get them on: SGLT1, beta blockers, ACE, ARB, or ARNI. So ACE being like lisinopril, ARB being like losartan, or ARNI being Entresto. And then either spironolactone or eplerenone for mineralocorticoid. But all of those can, lower your blood pressure. And we usually titrate the medications where the patient's blood pressure is maybe like 100, 110 at baseline. So any disturbance from that is going to result in them being a little bit orthostatic. Again, pulse is really a big thing. If you can only pump a set amount of blood, the only way to increase your cardiac output is for your heart rate to go faster. Conversely, patients where their heart rate is going fast, if you give them something to slow their heart rate, they actually do worse, because that's their compensation. And if you take away their compensation, then they end up in a worse situation. That's why in the hospital, if someone's, especially with reduced ejection fraction, if they come in heart failure, we don't start beta blockers until their volume status is completely normal. Beta blockers are excellent for long-term care, but in short-term care, it'll reduce cardiac output by reducing pulse and also contractility of the left ventricle and result in actually worse outcomes. Again, orthostatic changes, jugular venous distension is a big one. You can sometimes hear an S3 when you're listening to people, which is just an extra heart sound. Instead of the lub dub, it's lub dub, and then an extra sound after that. Peripheral edema, ascites, all that stuff. Cool lower extremities is generally a worse prognostic factor. That means that their cardiac output's just not sufficient. If they're, wet, as in fluid overloaded, and their extremities are warm, that's going to be someone that is going to respond well to diuretics. They're going to get that fluid off, and they're going to do well. People that are cold and wet, they're not going to do well because their cardiac output's just not enough to actually pump the blood around and get the blood off their body. The kidneys also require a decent amount of blood flow as well. So if they're unable to provide that blood flow to the kidneys, the diuretics are not going to be nearly as effective for them. Lab work that we usually obtain: CBC, urinalysis, serum electrolytes. Calcium, magnesium is also important. I think magnesium most people measure. Calcium is another important one, especially ionized calcium. Calcium is required for contractility of the heart. Having very low calcium can lead to cardiac arrhythmias and just poor calcium processing involved in the contractility of the heart. Lipid profile is more of a risk factor thing. The most common cause of having a weak heart is blockages, coronary artery disease. Renal function, of course, is important. Mostly, at least for you guys, it'll be important in if the kidneys are not functioning well, then the diuretics are not making it to the kidneys to be excreted to actually then cause the diuresis. Liver function, thyroid stimulating hormones, always an important one, get an EKG. This is more outpatient stuff, but hemochromatosis, this is described as bronze diabetes because it's a retention of iron issue, and they will develop diabetes and also bronzing of their skin. And that deposits in the cardiac myocytes and causes usually initially fibrosis with a heart failure preserved ejection fraction picture, and then the heart becomes weak just from the inflammatory issues related to iron deposition. HIV, not as big in this area, but definitely causes preserved ejection fraction usually, and that's again due to fibrosis. Rheumatologic diseases, there's not enough rheumatologists in this country just in general, so a lot of these are not really well taken care of. Amyloidosis is kind of becoming bigger because we can treat the what was previously called senile, the ATTR amyloidosis, which is what you develop later in life. There's medications for that. The AL amyloid, which is from the lambda and kappa chains, and that is something that you'd rule out before going to the other one. Pheochromocytoma is pretty rare, but that's basically just your body's dumping a ton of adrenaline. This is just more cardiology related stuff, but outpatient, they actually do recommend getting a BNP or a proBNP. If they're not elevated, you can pretty much rule out heart failure. If they're elevated, it's hit or miss. So the sensitivity is very good, as in if it's negative, it rules it out. The specificity is like about 60%, depending on where you put your cutoff. So it's not that great for ruling it in. The hospitalized patients always, you can trend it to in the hospital. If outpatient, their BNP, let's say, was 1,000, which some heart failure with reduced ejection fraction patients will just live at that level. If now it's 3,000, they're definitely an exacerbation. You can get chronic compensations where chest x-ray actually looks normal, but they're in a heart failure exacerbation, and that's just because the arteries in the lungs will actually become thicker and resist that cardiac asthma picture where the blood is being pushed through there. So their chest x-ray actually doesn't look too bad, but they're in heart failure, and one of the clues for that is that the BNP will be elevated. So there's other reasons for elevated BNP as well. One of the big ones is pulmonary embolism. You'll get an elevated BNP just from the stretching of the heart from blood not being able to get through the lungs. Atrial fibrillation causes dilation of the left atrium. If you're chronically in it, your BNP will be a little bit higher. Just being older, there's different cutoffs for ages related to BNP. Renal failure is a big one, for fluid overload as well as reduced clearance. Sleep apnea, again, big one. Pulmonary hypertension. Sepsis is another one. You can actually have a very weak heart from a bacterial infection that gets better once you resolve the bacterial infection. And I mean weak to the point of being like, 20, 25%, and then you get rid of the infection, it goes back up to, 50, 55%. Chemotherapy is a huge one as well. Usually you monitor, there's certain chemotherapeutic drugs are cardiotoxic. Some are cardiotoxic to a greater degree than other ones. Doxorubicin, daunorubicin are the big ones, but that can definitely, reduce your ejection fraction. So this is just the cutoff. You can see the sensitivity is very good, 97, 99%. If you use a different cutoff, it goes to 90%. Most of the cutoffs you see in the hospital are actually the ones at the top, which are 99%, less than 300 for NT-proBNP, but then the specificity is only 68%. So, it's kind of a give and take. As you can see, if you increase it up to 900, then the sensitivity is 90% and the specificity is 85%. So you're then missing 10% of the people, but then you're not misdiagnosing people in heart failure that don't have heart failure at quite the same rate. All these biomarkers are unfortunately a give and take. And again, people that have heart failure with reduced ejection fraction, they'll live with higher BNP levels just because they're chronically having some stretching of their heart. NT-proBNP is not affected by Entresto, which is sacubitril valsartan. BNP is affected by Entresto, and it'll be artificially elevated because part of the mechanism of Entresto is actually increase the levels of BNP. And BNP is brain natriuretic peptide, and that actually causes a bit of a natriuresis, which is loss of sodium, which causes a little bit of a diuresis as the fluid follows the sodium. So part of the mechanism action is for Entresto to increase that, so that'll be artificially elevated. But the NT-proBNP is actually a product of the BNP molecule, and that's not artificially elevated by Entresto. What should you do first for imaging? Get a chest x-ray. The heart size thing is tough in larger chest diameters, just because of the distance between the imaging and the receiving plate. It can show that the heart's larger with larger diameters, and that's really more of a factor of there's being more distance and the heart actually being large. We'll get a lot of cardiomegaly consults, and it ends up not actually being cardiomegaly just because of a larger chest wall. We get an echo on everyone, pretty much. These are things that are reasonable. Anyone with a reduced ejection fraction really should undergo some kind of rule out for coronary artery disease, just because it's by far the most common. If, let's say, for example, you have someone that's heart's been weak for quite some time and you're wondering if you should revascularize them, you can do viability assessments. There's no point providing blood flow to a segment that's dead. You can do MRI. It's a little more intense, not as common, but if you're ruling out more rare causes of heart failure, then it's a good test to go with. So this just basically says just don't keep repeating the echoes over and over again. If there's a change in clinical status, then you can, but don't do it just routinely. Pulmonary artery catheters, really in someone that's in the hospital and you can't diurese them, then you can put in a pulmonary catheter and measure their pulmonary pressures in that and try and diurese based off that. It is invasive, but in the patients that you just can't empirically, without this information, get them better, then it's definitely a viable option. And that's further on this. If they're refractory to medical therapy and they're just, and also it's good to determine the etiology. Is it, severe pulmonary hypertension also contributing to the fact that you can't get this patient out of heart failure? This will give you information on that. If they're consistently in cardiogenic shock, then invasive monitoring is worth it. Worsening renal function is another thing. You can get really two major types of renal dysfunction in heart failure. One is where they're just not perfusing enough. You're not getting enough blood flow to the kidneys. The other is congestive kidney disease, where basically the blood's getting to the kidneys, but it's not leaving the kidneys quite as well, and the kidneys are actually getting congested from that. So don't do it in patients that have normal blood pressure, and it's definitely not a routine thing. So what's the goal of treating all these people with heart failure? Really to live a better life, to get rid of their symptoms, to get them as healthy as they can be. Cardiac rehab is amazing for these patients. We have a heart failure nurse practitioner, and I have some patients that are, I don't want to say difficult, but they're just complicated, and they see her once a week. Like I have some patients that see her once a week just to keep them out of the hospital. I have one gentleman who, every time we would go in the hospital, he would spend like 2 or 3 weeks there, because he's really never well enough to where the hospitalist is like, oh, this guy looks good and he can go out. But having him see the nurse practitioner every week, he's been out of the hospital for like 6 or 7 months now. And she actually tried to decrease the amount of time that he was seeing her and had him follow up in, I think, 2 or 3 weeks. And he actually then emergently came in and we had to give him, diuretics and that. So some patients really need the, constant monitoring and that. And he actually lives, he's not an athlete by any means, but he lives a reasonable life. And we keep him out of the hospital, which is much better. In the hospital, people just lie in bed. They become debilitated. They don't do well. Even though physical therapy comes, it's much better to be out and active in the community. Cardiac remodeling, that's really why we start all these medications. Your body is designed to, get attacked by a lion and live to the next day. Your body's not worried about 30 years from now, 40 years from now. So you'll release a whole bunch of hormones that are not good for your heart long term. That's why we start people on the beta blockers to reduce the amount of adrenaline. Your kidneys produce a whole bunch of hormones that your heart doesn't like. That's why we start them on either ACE inhibitor, angiotensin receptor blocker, or Entresto. And those medications can actually reverse some of the damage from heart failure. It's fairly common to see people that we start on those medications, their ejection fractions like 30-35%. A year later, it's 50-55%, and that's an entirely different picture of a patient. You do want to continue those medications if their ejection fraction recovers. There's a lot of data on that. If you stop it, it usually, unfortunately, goes back down to not being great. The ultimate goal is to decrease hospitalization. Hospitals are really there for if you need to get out of a bind, but heart failure is really a chronic disease, and outpatient follow-up and outpatient monitoring and management is significantly better. And the ultimate, outcome is to improve mortality and patient outcomes. So stage 1 heart failure, these are recommendations for it. Basically just risk factor modification. Control hypertension, decrease your cholesterol, stop smoking, stop doing meth, control your diabetes, lose a little bit of weight. Then you have, and those are the people that have no symptoms. Now you have the people that have structural heart disease. These are people, ventricles a little bit thick from having high blood pressure for a while. Anyone with diabetes is at risk of, having heart failure and that. But these are people you've actually diagnosed that they have something going on. Either their ejection fraction is not completely normal, maybe it's 45%, it's not terrible, and they're actually doing fine, or maybe they just have, a little bit of diastolic dysfunction where the heart doesn't relax as well, but they have no signs or symptoms. For these people, we do actually start putting them on medication. So with reduced ejection fraction, and it should have ARNI there too, but an ACE inhibitor, ARB, for anyone that's had a heart attack in the past or anyone with a reduced ejection fraction, helps reduce mortality. Beta blockers for anyone with a history of MI or reduced DF reduces mortality. Statins, again, if you had a heart attack in the past, you probably should be on a statin. Nowadays, if people are statin intolerant, we do have injectable medications, either Leqvio, Repatha, or Praluent. They all really do the same thing. Repatha and Praluent you inject every 2 weeks yourself. Leqvio is every 6 months in the hospital. Repatha and Praluent are better covered by commercial insurance. Once you hit Medicare, Leqvio is a better option because Leqvio is under the hospital benefits of Medicare, so it covers it very well, whereas the pharmaceutical benefits when you're a Medicare recipient is dependent on whatever plan you paid for. Blood pressure control is always important. I always do outpatient blood pressure logs. The blood pressure we get at one point in time in an office visit where we hurried them into the office, sat them down, and immediately took a blood pressure is not reliable at all. You want to see what their blood pressure looks like outpatient. ICD, for anyone that's at least 40 days post-MI with an EF less than 30%, or if you reach 3 months and it's less than 35% on maximally tolerated GDMT. Non-dihydropyridine calcium channel blockers are verapamil and diltiazem. Both of those decrease the contractility of the heart, so they're actually a class 3, which is there's a harm in using those in patients with low ejection fraction. Their issue is that they're not pumping enough blood, and now you're giving them medication that makes them pump even less blood. Now you have the people that have been in the hospital or currently are having symptoms. Monitor your symptoms and weight fluctuations. Take your medications. Keep being physically active. Sodium restriction's good. CPAP is honestly excellent. I feel like almost everyone has sleep apnea at this point. It not only helps with the heart, but it actually, in general, decreases mortality. Much better functional status. A lot of people, they're constantly tired. They get on CPAP and they feel like an entirely new person. Cardiac rehab says can be useful. I think it is useful even in clinically stable patients. And that doesn't necessarily have to be official cardiac rehab, just going to the Y, do some water aerobics or whatever. The patients that I have that stay active usually do significantly better than the ones that just sit in the recliner and watch TV all day. So again, ACE, ARB, ARNI. Ivabradine is almost never used for this reason. Ivabradine works on the funny sodium channels in the heart, which reduces your heart rate in sinus rhythm. Its official approval is for heart failure patients. 90% plus of the people that are on it are young women with fast heart rates, which is an off-label, and then you have to fight with insurance. To use it in heart failure, you really want to be on the maximal dose of the beta blocker, carvedilol, metoprolol, whatever, and still maintaining heart rates that are faster than 70 at rest. It's fairly rare that you end up with these patients. Usually once you titrate up the beta blocker, their heart rate's pretty slow. And this is for heart failure with reduced ejection fraction. And then just when you're transferring over from an ACE or an ARB, just an ACE over to an ARNI, you want to wait 36 hours because the ARNI, which is Entresto, contains a angiotensin receptor blocker, and if you take that concurrently with an ACE inhibitor, you can get angioedema, and you can also get very high potassium levels. These are recommendations for medications to put people on. Kind of went over these in the prior slides. CRT down near the bottom there. If their ejection fraction is less than 35% and they have a left bundle branch greater than 150 milliseconds, these patients, it's about 2/3 do very well with the cardiac resynchronization therapy, which is basically a pacemaker to pace the right ventricle and the left ventricle simultaneously, so you actually increases your cardiac output since they're synchronized, whereas when they have the left bundle with a greater than 150 millisecond duration, the right ventricle is going to contract and then the left ventricle is going to contract afterwards, and the left ventricle doesn't completely contract in a organized manner because some will contract before the other does, and it reduces your cardiac output. So if you do the cardiac resynchronization therapy, a lot of these people have an increase in cardiac output. ICD for anyone that's, heart failure less than 35% ejection fraction, greater than 40 days post-MI, on maximally tolerated guideline-directed medical therapy. That one is usually only approved by insurance if it's less than 30% at 40 days post-MI. What they will approve is less than 35% if you've been on maximally tolerated medical therapy for 3 months. And that's just a Medicare requirement. Back in the day, they would just put these devices in everyone, and it was not a good situation. If people aren't doing well, you basically have, 3 options, really. You can either put them on palliative care. You can send them for transplant. That's usually younger people that are, still good candidates. You can put an LVAD in. LVAD is a left ventricular assist device. It's basically a pump that goes in your heart and pumps blood for you. They're not fun. They're big. They have a drive line that comes out of your body. You have to hook it up to a battery. They're more of a temporizing measure. I forget which president it was, but some president needed an LVAD, and basically all the approval for LVADs are because that president needed an LVAD. They're okay, but they're not, really long-term options. Transplant's excellent if you're a candidate. So aldosterone, this is spironolactone, eplerenone. There's a new one, finerenone, that's ridiculously expensive. So this one, if their ejection fraction's reduced, or if it's reduced less than 35%, and their renal function's not bad, these will raise your potassium. So always something to look at, someone that's on this outpatient, their potassium levels can get pretty high. You really should not be on a potassium supplement and one of these medications at the same time, because if your potassium level does get high, you can go into arrhythmias and just, be dead by the time someone finds you. You do want to monitor potassium levels. This is a weird combination, but if you ever see someone on hydralazine and isosorbide dinitrate, they probably have heart failure. There's really no other reason to be on this medication. It's used in 2 situations. One is African Americans. For whatever genetic makeup, African Americans do very well on this medication. Caveat to that trial, it was whoever identifies as an African American. So you have, different lineages mixing in that, but that's what they found in that trial. And then anyone that has, really bad kidney disease and can't be put on, ACE, ARB, or ARNI, then you end up using this. There is a brand name medication called Bidil, which is this combination. That medication is prohibitively expensive, so almost no one's on it. They're usually on generic hydralazine and generic isosorbide dinitrate. These are doses of, loop diuretics, thiazide diuretics, potassium-sparing ones. So unfortunately, Lasix is the most commonly prescribed loop diuretic. It's, I think, the second diuretic that came out. The first one was, I forget the name, but it's one that's never used anymore. Lasix has the issue of bioavailability. On average, you absorb about 50% of it. That can vary. Again, if you have the abdominal edema, you absorb significantly less. Bumetanide and torsemide, you usually absorb 100% of it. Bumetanide is shorter acting, similar to Lasix, where it acts for about 4 to 6 hours. Torsemide acts for probably about 8 to 10 hours. I like torsemide personally. That's what I use. Actually, they put 12 to 16. That's probably at higher doses. The other issues you run into with Lasix and Bumex is if you're taking it just once daily in the morning, your body compensates by retaining salt. So if you have a salty dinner, you retain all the salt from the dinner. So you then really are not gaining very much from being on that diuretic because you're going to diurese in the morning and then retain overnight. Torsemide does not have that issue because it works a much longer period of time. Twice daily dosing of Bumex and Lasix also solves that issue. I never have them take it at night. I usually have them, I don't prescribe Bumex very much, but for Lasix, I'll have them take it when they wake up and then about 6 or 8 hours later. Just so you're getting, when it starts wearing off, you're getting the second dose, you're not peeing all night. The combination of loop diuretics and thiazide diuretics is really the main one that we use is at the bottom there. It's metolazone. Metolazone is not the strongest thiazide diuretic, and that's kind of why we use it. If you're on a loop diuretic and a thiazide diuretic, the fluctuations in your sodium levels, in your potassium levels, in your magnesium levels is going to be rather wild. Patients that do need metolazone in addition to the loop diuretic are usually people that have very bad chronic heart failure, usually people with some kind of kidney disease. You don't want to use a loop diuretic with hydrochlorothiazide and definitely not chlorothalidone. Those are both stronger thiazide diuretics, and you can end up with really, really bad electrolyte abnormalities. I've seen a few patients on hydrochlorothiazide in addition to loop diuretic that are getting treatment at tertiary care center, and that's just all that they can tolerate. The potassium-sparing diuretics, amiloride and tramtarine, are really just used for blood pressure. Spironolactone will be the most commonly used. That's a mineralocorticoid receptor antagonist. And again, you don't want to take potassium supplements with spironolactone. All the thiazide diuretics are really used for hypertension unless they're being given in addition to a loop diuretic. Loop diuretics are where the money is at for heart failure. And then they'll also have different doses between the oral and IV. For Lasix, it's about twice. Bumex and torsemide are roughly equivalent since their bioavailability or the amount you absorb is very good. This is just a list of medications used. It's interesting because on the third column there, that's the mean dose that's achieved in clinical trials. Some of these medications are older. Captopril and Allopril is not prescribed as much anymore. But if you notice, it's kind of weird. Carvedilol, they reach 37. That's not even a dose. You have an option of 25 or 50. Bisoprolol is not as commonly used in this country. It's used a lot elsewhere. It's once daily instead of twice daily. It's slightly more cardioselective than metoprolol. If you notice, the metoprolol dose in the trial was 159. Not many people make it up to, the 200 milligram dose of metoprolol, but that is, 159 is what they were given in the trials, and that's where they have the effect. So these effects are really at higher doses of the medication. Spironolactone is actually just as a starting dose, it was 26 in the trial, 25 is what we usually start people on. And eplerenane's roughly half as strong as spironolactone. Spironolactone, for a side effect, men can actually get gynecomastia, which is much more common in elderly men. But eplerenone is more specific for just doing the mineralocorticoid, not affecting testosterone as much. So in those men, you switch them over to eplerenone. So this is, again, the bioavailability. Bumex is, 80 to 90%. Torsamide's 80 to 100%. Lasix, it says 50% there, but varies. If you look at the trials, it's anywhere between 20 and 60%. And again, if you develop the gut edema, then you're not going to absorb the Lasix nearly as well. Ethacrinic acid, that's the original loop diuretic. That probably doesn't even exist anymore. Lasix drips, the trials show that there's really no benefit to Lasix drips versus pulsing the doses of Lasix. But in clinical practice, I think there are some situations you want to use the Lasix drip. Bumex drip is another option, just the doses are much smaller and it's a little bit more annoying to titrate. You can do a 5 milligram dose, but again, you get the wild fluctuation in electrolytes. This is really looking at the trials and how many people the number needed to treat was to actually reduce, mortality. And if you look, it's actually really excellent. That's the second column here. So only need to treat 7 people with hydralazine and isosorbide dinitrate to prevent the mortality. 6 with an aldosterone antagonist like spironolactone, 9 with a beta blocker. The ACE inhibitors and ARBs was 26, not quite as good, which is a little interesting because almost every patient ends up on a beta blocker and an ACE or an ARB or an ARNI, but not quite everyone ends up on the aldosterone antagonist. And if you look at the number needed to treat, it's actually the best for the aldosterone antagonist. So this is kind of a summation of this. Since I realize you guys this is kind of, more of an overview for chronic management and that, more of a expose you to a bunch of information. But I understand you guys deal with, the acute people, the people that are, in heart failure, and you just need to get them stable into the hospital. How much Lasix? I think 80 is never a wrong dose. The issue, 40 is probably, I don't know, do you guys have a specific amount you normally give, or? Oh, you don't carry Lasix? Oh, okay, okay.
At the local services here, there are some EMS services out there that do carry it.
Okay, yeah. So if you did carry it, 40 milligrams is kind of the most common dose that people give. But the issue you run into is you don't know what that patient's renal function is. You don't know how much of that is going to make it to the kidneys to actually diurese them. 80 is usually a reasonable dose. Most people, unless they have really bad kidney disease, will diurese with 80. If you look at the trials for how much Lasix is given, the doses that they go up to are astronomical, like 200 milligrams IV, absolutely wild doses. You don't see that as much in clinical practice, but if you look at the data, that's really what it supports. With higher doses, you usually don't get actually that much worsening of electrolytes in that. It obviously is a little bit stronger, but there's a limit to how strong it can be, just how it functions. The real issue you run into is actually tinnitus. They'll develop ringing in their ears. Oxygen saturation, really just keep it above 90%. A lot of these people, if you get them to 100%, their respiratory drive is just going to crump out and they're not going to do well. Sublingual nitro can actually help in heart failure patients. It reduces preload a little bit, so which is the pressure going into the heart. Really, for people with higher blood pressure, you don't want to just give this to someone where their blood pressure is like 110 or lower, but if their blood pressure is like 150, 170, a little bit of sublingual nitro can help them, with their symptoms. Definitely avoiding people taking ED meds. In the hospital, we actually use, very rarely, you actually have to use a swan to invasively measure, but we'll use nitroprusside, which is a stronger version of nitroglycerin, which will actually reduce preload and afterload for really bad heart failure patients. But that's the end of my lecture. You guys have questions or anything?
The live stream is 15 to 20 seconds or so.
Okay.
So, see if there are any questions. They didn't a few minutes ago when I asked.
Anybody in here have a question?
Okay. All right. Not now.
Really? Yeah. I mean, it's tough. The transit time to the hospital is generally not that much, but it can help. Yeah.
If I remember right, what the issue that we had is that we had a few providers that were struggling to differentiate between asthma and CHF or something of that sort, COPD and CHF.
Yeah.
So they were giving Lasix
For
COPD. Patient.
Yeah.
It was causing some chaos. So
Yeah.
I remember right, that's partially why they pulled it from. Does that sound familiar to you?
Yeah.
Maybe not so much.
We got pushed back at the hospital because it all lose their labs.
Oh, yeah, I could see that. And again, your transit time to the hospital is not going to be too much. So, they're not going to feel infinitely better in, a 30-minute ambulance ride or anything. So, I mean, I guess that kind of makes sense. I'm sorry? It depends on their renal function. Someone with a normal renal function, you're probably looking at like 30 minutes or so. Someone with renal dysfunction can be much longer. Yeah, so by the time they get to the hospital, yeah, that's when they're, yeah.
The nitroglycerin CPAP was
Mhm.
more of a difference.
Yeah, oh yeah. CPAP, BiPAP's excellent too.
Right, yeah, BiPAP.
Just basically and that's basically just pushing the fluid out of the lungs back into the circulatory system, yeah.
More popular than the
Oh yeah,
others.
yeah, no, that's a good option.
You're not worried about the preload when we start doing that aggressively?
Not really, to be honest with you. It's tough because you guys are acting on very little information. In the hospital we have all this tons of information. You just got to see them, they're acutely in distress. You're kind of acting on minimal information, really, just physical exam, what you can gather for information. So nothing's ever going to be perfect in that situation. You just don't have enough information. But unless you know that their ejection fraction previously was very low, then I think it's kind of a risk you have to take, I'd say probably 90% plus it's going to help. And the people that, have a very low EF, if you put it on, their blood pressure is tanking, then, yeah, unfortunately, yeah. That's all you can do.
See any more questions on that?
No, lots of thank yous and a couple of great lectures and stuff like that. No questions from the online audience.
All right, cool.
Well, we appreciate you
Yeah,
coming in.
absolutely.
Absolutely. It's been
Sure.
great. We
Pleasure.
were able to get it.
Yeah.
Your email finally coming.